Shall now go on to our next eminent speaker, Dr. PANNEER SELVAM, who's director of the Arasan Eye Hospital, E-Road. And I'm sure all of us know the kind of surgical training he has given over the years, and the kind of community service he's been doing is extremely laudable. And I'm sure he's very experienced to tell us about MSICS in a black cataract. On to you, Dr. PANNEER SELVAM.
Thank you, Dr. Chitra. Thanks for the wonderful opportunity and excellent program that you have. The challenges in black cataract. What are the challenges? The nucleus is big. The zonules are very fragile, and there is always usually associated with pseudoexfoliation. So how to manage such case by doing SICS? First is wound construction. The wound construction is a bigger incision, and there should be adequate scleral pockets. The most important
slide is not moving, sir.
No, I'll do that.
Yes.
Yeah. This is the incision we make. So routinely, a frown incision, a bigger size, more than 7.5. You should be liberal in your.
Sir, the PPT is not.
Sir, we can't see your slides.
Can't see.
It's fixed on the first slide only, sir.
Sorry.
We can only see your first slide, credit slide.
No, now you go back to slideshow.
Yeah.
Go to the next slide. And
Yeah.
You'll have to click on the slide, sir.
Am I visible now?
no, we are not able to see the next slide. Would you try stop sharing and share again and see?
Sir, when you share, you're sharing, not sharing the entire screen, you're sharing the application. So you can try sharing the entire screen, sir. It should work. Yes, sir. Just try again. Yeah,
Yes.
now
Yeah.
it's working, sir.
Yes.
Yeah. A
Yes.
bigger incision, the regular frown of 7.5 mm in size or more than that. You should be liberal in your incision, and it should be the tunnel making should be proper, and go through that, and then concentrate on the making a scleral pocket, adequate scleral pocket, both sides, and moving from the cornea to the scleral side. You can avoid the buttonholing. Now make for the side port, put Triffon loop. Now enter. This is very important. Too advanced to make high astigmatism. Too near proximal, you will have fish mouthing. The entry should be, you should always cut while opening. This is the important thing. Next is, this is another important, very interesting approach by Dr. Pradeep Mohanta. He has a double SICS. He makes two SICS wound joining at the on tip. So it makes for a bigger opening. And it also facilitates suturing at the end. So regular tunnel, open up. So a big opening is, tunnel is made, enter as a regular one. And then after putting a lens in, you can always suture and make it tight. This is a very interesting one. So next is the capsule management. The rexis has to be large and really large. And that if you are not able to make larger rexis, you should always opt for a relaxing cut or even a can opener if you are not very sure about your rexis. Always have the pupil as the marker and go along with the pupil so you will not miss it. And fixing the globe with the left hand and then making a rhexis is always easier and approachable. And make small, gentle hydrodissection. We should not force because of the big volumes. So now the nucleus prolapse. This is where a problem comes from. Many of the young surgeons. There should not be any stress on the volumes. It's always better we have 2 hooks applied, one above and one below, and then dial out the nucleus. This is very important. You always go underneath, inject viscoelastic, take 2 hooks, one below, hold it, and the other one rotate, dial it out of the bag. Now is the nucleus delivery. This is where the comes. Once the nucleus comes into the bag, out of the bag and into the anterior chamber, what we have to consider is this size and the incision size match? Whether this nucleus will come out of the incision that I have made. Most of the problem comes with the incision nucleus mismatch. So if you find the incision smaller, you should not hesitate to extend the incision. Then the technique comes. Either you can use the irrigating vectors if you are well versed, or you can go for a sandwich technique. The irrigating vectors go underneath, push, and then maintain the pressure and bring out the nucleus. Very well, it will come. Yeah. The other thing is sandwich technique. Here the incision is very long. Only catch here is you should, because of the visibility problem, you should not catch the iris. So always in the middle, you pull out as one unit. So this is another way of doing. Then IOL implantation. Here is catchword is very gently. Go, be careful with your cortical aspiration. Look out the fluid flow. It should not be very fast. And put an appropriate lens, either PMMA or a 3-piece or even foldable, depending on the capsular support that we have. So this is how a black cataract is made. And if the wound is tight, the stromal hydration is made. Check whether the wound is watertight, then there is no need for any suture. You can close it as it is. So black cataract managing is not different. Only thing you have to refine the steps. The incision has to be big. The rhexis has to be larger. The prolapse have to be gentle. You should ensure a very safe delivery out of the eye. And the cortex aspiration must be careful and do an implant a very appropriate IOL. So this is how we are managed. The only thing is, if you are a regular surgeon, what you have to consider is the patient. If you are a regular surgeon, the ego comes in, whether I can manage. It should not be a point whether I can manage, whether this is helpful for the patient in my hand. If it is not, SICS is a very good technique for managing a very hard cataract. Thank you very much.
That was a brilliant presentation, Dr. Panneerselvam. Such important take-home points like the need for a large incision and the different options of incisions which you showed were all excellent, and of course making a larger rhexis. But the question which I would have is, what would be the technique? You would do a large incision. You have shown two ways of making your incision. What would be the way to go? I would ask Dr. Debashish and Dr. Patwardhan.
Chitra, yeah, I mean, yeah, the incision for a big nucleus has to be adequate, be it at the capsular level, the rhexis has to be big. At the incision level, there are 3 levels of incision. One is the internal incision, which is so the corneal valve has to be dissected as far down to 3 o'clock and 9 o'clock. So the internal incision is big enough. And then the incision might get stuck in the scleral pockets. So, I mean, in the tunnel itself. So we must have adequate scleral pocketing. So we must remember that the incision, these hard cataracts are not only big, in size or in length. It is thicker also. So, you need that thickness in the tunnel. So the scleral pockets are important. And of course, as Dr. Paneerselvam said, that you need an external incision, which should be adequate and big enough. I would prefer a frown incision. And the only objection to a straight incision here, because you cannot continue a straight incision big enough. So, frown you can still enlarge further if you have any limitations of the external incision. And in case there is any disproportion, which Dr. Selvam mentioned, and you get stuck at any point, don't pull up the nucleus, because it is an automatic reactionary thing that we pull up the nucleus. Let us understand one basic fundamental thing of the SICS incision, that when we lift the upper incision, the incision closes. When you press the posterior lip, the incision opens. So all you do is just press the posterior lip, take out the instrument with which you are taking out the nucleus, push the nucleus in, and then correct the incision at whichever plane the disproportion is, and then proceed a second time. So that's it.
Dr. Ravindra, would the kind of black cataracts Dr. Paneerselvam showed, would you still consider doing a premium IOL on these patients?
Yeah, why
Yes,
not?
well, why not? Yes, certainly.
Bisect it and do it.
I will not even have a backup lens. I'm sure that we can put a multifocal lens in this patient, provided your biometry is good. You need to enter AC depth and lens thickness in your biometric calculations. Otherwise, you'll go hayway.
Yeah, but your X's has to be larger.
X's has to be large.
Yes. So anything else anybody would want to ask Satyajit, Anagha, before we go on to our next speaker?
I have a
Let's
question.
go to the next speaker, ma'am.
No, yes, Dr. Ravindra, what
One
question?
small question,
Yes.
and his videos were just superb, just superb. And I just wanted to know how he irrigates when he takes it out. I've never used irrigating wire vectors. Any tips for using irrigating vectors and the type of irrigating vectors that he showed?
Yeah, irrigating vectors, you have to go in with fluid, and then with the pressure you have to build up. It's only with practice you have to take it. But in a doubtful case, I feel the sandwich is much better than irrigating vectors in these cases.
One question is, when you go inside and irrigate it, will not the the lens goes up and sticks there? Like the pressure is from behind the lens. So how do you maintain the space between the endothelium and the moving lens?
Now already the lens will be floating within the viscoelastic. That is the only thing, and usually it doesn't cause that much of a problem. Only here that cases the nucleus molded itself into the tunnel and came out. Otherwise, if it is open, it will come out.
Do you have any, Debashish, you can answer this. Is there any calculation possible to assess the size of the nucleus and then customize the tunnel? So you sometimes, you expect a large nucleus, and you make a big tunnel, and you end up, looking at a small nucleus which easily comes out. Is there any tips as to how do you match the nuclear size versus nuclear thickness versus the tunnel size?
I always find when I inject viscoelastic, if there is iris is floating, comes up, then I feel incision size is not enough. Then I extend. It's better to extend rather than minimize. So I always start with 7.5, inject viscoelastic, and then before taking out the nucleus, if the iris comes out, the space is not enough, I extend it and then.
Yes.
One question is, earlier when we were doing ECC, I used to use Maloney's keratoscope, to titrate the incision. I mean, any one of you use keratoscope to, titrate the tightness so that you end up with least amount.
MS, to answer two of your points. One was the irrigating vectors. Now, irrigating vectors, you can connect it to the drip, or you can use a syringe and continuously keep on irrigating. Now, all that you are doing is, you are taking the eye down and then you are irrigating, not pressing on the posterior lip.
Okay.
Now you take the eye up and align the nucleus with the incision, and now you are only depressing the posterior lip. The irrigation is continuing. I mean, like you keep on injecting viscoelastic in your cannula while you are bisecting to protect, stay away from the endothelium. So I mean, with the irrigation, the iris or the nucleus floating up, touching the endothelium, or the iris being pushed down is not a possibility.
Okay.
The second question is, I mean, if you have made a 7 or 8 millimeter incision, I mean, in the post-op period, it is only the central portion. If your incision doesn't slip in front, then the astigmatic factors, I mean, if the incision is scarring in this meridian, that will be neutralized by the scarring on the other meridian. So essentially, it is the central 3-4 millimeters which is astigmatically matters. It's not. It is the coaptation of the wound, I think, or the entire incision which matters.